Hi, everyone. Thanks for being here. We're going to give it like 2 more minutes for people to get away from their desks and their patient care if they can, um, and get themselves in, and then we will start the show. All right, it's a couple minutes after, and I'm impatient, so let's just get started. Um, I'm Rebecca Dunsmore Sue. I'm Chief Medical Officer at Genève, and we host these Menopause 201 webinars to sort of explore a little deeper topics around menopause for physicians, practitioners of all sorts, so that we can sort of talk through evidence-based care around menopause. And before we start this, and I let Dr. Fuller introduce herself, I just wanted to make clear we're doing this whole session on non-hormonal therapies not because we think they're first line. Dr. Fuller and I think, are both pretty big advocates for hormone therapy, but sometimes you need to understand the non-hormonal options. So we wanted to really do a bit of a deep dive because there's some new stuff out there. There's a great new position statement last year that we'll talk a little bit about and just be able to give you some really concise and helpful information. So I am thrilled to introduce Dr. Ashley Fuller. Dr. Fuller and I have worked together for many, many years. I used to assist her in the middle of the night on C-sections when I was a hospitalist and she was in private OB practice. And then I went menopause only. She went GYN only with a focus on menopause and sexual function. We came together and had a practice. We've split apart as I came to Genève, and she is now in private practice in Seattle. So, Ashley, tell the folks a little bit about yourself.
I feel like you just told everybody everything. I'm kidding. Well, thank you for having me. I think these webinars are great, and I feel honored to be here talking about this. And I agree. I think it's a good way to think about it in the sense that hormones are great, but they're not for everybody. So I think it's good that we talk about this. But yes, I'm Ashley Fuller. I'm a board certified OBGYN. I was a generalist for 9 years and then decided I couldn't do it anymore and was exhausted and burnt out. And I realized that, one of the deficits in my training and in my knowledge in taking care of women was really this space around menopause, sexual health, and complex vulvar diseases. And so I really dug in and have done a lot of self-education and learning over the last 5 years and really just focused on that. I did it within a healthcare system along with Dr. Dunsmore Sue for a while. And I just started my own micro practice about 5-6 months ago. So I'm certified by the Menopause Society. And thanks for having me. I'm excited to be here to talk about menopause.
And just so y'all know, Dr. Fuller also speaks for Astellas on the topic of Veoza. So we do still work together in the setting of clinical research, and both of us did worked on some of the trials for them as well as for Bayer, and we'll talk about all that. So Ashley, let's start with who isn't a good hormone therapy candidate? Why are we even talking about this? Why don't we just put everybody on hormones, which, is kind of what people are asking for now.
Right. Sometimes I wish we could, but
Mm-hmm.
as being good physicians, we want to talk about risks and benefits. And there are some people that it's probably just too risky for them to be on hormones. So people that come to mind first are people who have a history of estrogen receptor positive cancers. So people have a history of breast cancer. It's one of the big ones. People have an underlying history of significant cardiovascular disease. So if they've had a stroke in the past or have had an MI or heart attack, and then people who have a higher risk of clotting disorders. So people with a prior pulmonary embolism, and technically someone who has a history of a DVT. Some of these there can be a slight gray area, and with a lot of counseling, some of these things can be not necessarily absolute contraindications, but they're definitely things that would give me pause and would be a very significant discussion about whether it would be safe and worth the risks to proceed with any kind of hormone therapy. But those are the main ones I think of.
Yeah. And how do you counsel them about trying a non-hormonal? Do you, like, if they're hesitant about hormones, do you start down that pathway? How do you talk about how these work?
Well, I mean, let people know that hormones are safe for some people and they're not for everyone. And that definitely, if there is a contraindication, that there are other options. There's not just nothing. And so, I look at, what are the indications they're looking to treat? As you know, as a menopause specialist too, some people come in and they have literally every symptom I've ever heard of for perimenopause or menopause. And some people come in and just have one single thing, like they just can't sleep or they have hot flashes and night sweats. I think when we take hormones off the table, hormones tend to give us kind of a more broad kind of symptom symptom improvement for a lot of people, not everyone. Whereas if we're going to take hormones off the table, we're kind of looking at what are the symptoms that are bothering you the most and what are our goals, because it's kind of like looking, kind of identifying those things and looking at what we could specifically treat them with. But it is letting them know that there is good research, there are things that are FDA approved that are non-hormonal, and there are options for them.
Yeah, it's a good way to look at it. It's always a much more difficult conversation because I think we do get away with a lot with hormones. They just sort of treat all the symptoms or most of the symptoms. Although increasingly I'm seeing patients in my practice who think hormones are going to solve every ill. And
Right.
sometimes we do have to manage expectations.
Definitely, definitely. I mean, like you mentioned at the beginning, I love hormones and they are first line for a lot of these things, but there's definitely patients who even can be on hormones and go on hormones and still are saying, well, I'm better in this area, but I'm not better in this area. And so I definitely think there's like everything, but definitely menopause practice. There's a lot of nuances to this, and trying to figure out like how to best treat a patient to meet their goals in a safe way is definitely kind of one of the fun parts about this job, because there is no one size fits all.
Very true. Very true. Sorry, I'm going to clear my throat. So one of the things that I always like to talk about is the common symptoms that we treat during perimenopause or postmenopause with non-hormonals. And I think the one everybody thinks of is hot flashes, right? We have a lot of different medications that we can use to treat hot flashes. What are some other things you think about as single symptoms that can respond really well to non-hormonals?
I mean, hot flashes are the biggest one, and I think it's one of the ones that we've had the most research on helping them. I also think about insomnia or sleep issues, and that's kind of a hard one because a lot of times these sleep issues are due to night sweats that are waking the patient up. So there's something, there's a kind of overlap there. I also think about mood. I think mood is a time in our lives where we see a lot of mood changes. I think so many patients report increased anxiety. And that also, I think, goes with the sleep thing, because so often patients tell me I wake up at 3 and I worry about things I normally wouldn't worry about. And, it gets this kind of adrenaline circular thought process of like, I can't sleep. Oh my gosh, I'm going to be so tired in the morning. Oh my gosh, I'm going to worry about this and this and this. And then you definitely can't sleep. And so we've all been there.
Yes.
So, I think that sleep can definitely be, mood is definitely part of this. And then it's not just anxiety. Sometimes we see more depression along in this time. So I definitely think those are symptoms that we can talk about non-hormonals treating.
And one of the ones I'm seeing a lot in my practice is weight, and the weight gain, weight changes, body composition changes that come along with perimenopause and menopause. And, I have to tell patients that hormone therapy alone is not going to fix that particular symptom. Women don't just lose weight when we put them on hormones. So often, if that's their main concern, we're talking about other strategies like lifestyle and weight management medications, depending on their level of obesity and where they are. So that's one that I've seen a lot.
Yeah, I completely agree with that. I mean, I tell patients estrogen tends to be a fairly neutral weight, medication. It doesn't necessarily make you lose weight. It doesn't necessarily make you gain weight. Obviously, every person's somewhat unique. So, I would say it may help support weight loss if your weight gain is because you don't sleep and you can't make good choices. You don't have energy to work out. Potentially, if it makes you feel better and you have more energy to do these things that lead to healthier habits that could lead to weight loss, but it's not a direct cause.
No, that's a really good point. And sometimes patients also think it's going to help the muscle build. And I talk to patients about that. There's the supposed sarcopenia of menopause, but there's also sarcopenia of aging. And in all honesty, I've looked into this. The data on muscle building with estrogen is from a mouse model. We don't have any clinical evidence that it works in women.
Mhm.
So being cautious about what you promise estrogen can help them do.
Yeah,
I think
absolutely.
taking enough protein in and doing heavy enough lifting is the best way to muscle build, whether or not you take estrogen.
I talk about those every day in my practice. Yes.
Amazing.
Yes.
So let's talk hot flashes because that,
Yeah.
like you said, it's where we have the most medication options.
Yes.
Um, what are our sort of our pantheon of options for hot flashes that are FDA regulated, non-hormonal choices?
Right. Yeah, I mean, I think vasomotor symptoms is probably one of the biggest concerns people have in menopause, but it's also where we have a lot of data and we actually have FDA approved products, so it is a
Hmm.
good place to start. So in terms of FDA approved products, we have SSRIs, so paroxetine or Paxil at a low dose, 7.5 milligrams, has been FDA approved for the treatment of moderate to severe vasomotor symptoms in menopause. It has a moderate reduction in vasomotor symptoms for patients. It can have some side effects like any SSRI. So there is that to think about. As a sexual health provider, I'm always thinking about sexual side effects also. There is that, but it definitely is FDA approved and can be helpful for patients. Then the other ones that are actually FDA approved are going to be the candy neuron medications, and that's Veoza, which is the new Astellas drug, or fezolinetant. We do have some, and we'll talk about that more in a minute. We do have some non FDA approved, they're not FDA approved specifically for vasomotor symptoms, but they're FDA approved for other indications that may be helpful. Things like gabapentin, so seizure medication that has been studied looking at help for vasomotor symptoms and has shown some statistically clinical significant clinical benefit for vasomotor symptoms. And then oxybutynin, which I generally don't use that often. It's an anticholinergic, has a fair amount of side effects, and has this question of this, like some studies with some dementia risk in it. But those are some of the not FDA approved for vasomotor symptoms, but you can use them off label for that.
Yeah.
Um, in
So
terms of
let's
the
talk a
new,
little bit about Veoza because I know
yeah,
you speak on the topic. It's a newer drug, so not all of us have had training in it. First of all, sort of what's the effectiveness that we see with it, and then what are the risks, and why are we doing all these LFTs?
yeah. Well, I always think it's good to think about how Veoza works. I think a lot of people don't know how it works because it's a new type of medication, or fezolinetant. So these are neurokinin receptor antagonists. So they work in the brain and the hypothalamus. And these are neurons that basically they found to be hypertrophied in postmenopausal women. So as we lose estrogen, there's more of these neuropeptides like neurokinin that are binding to these areas. And they found that if we block these, then it can reduce those vasomotor symptoms. Definitely non-hormonal, no hormonal aspect to them. Fezolinetant has pretty good clinical data looking at about a 50 to 60% reduction in the frequency and severity of symptoms of vasomotor symptoms, both in daytime and nighttime. So I would say it is more, the data is a little bit more robust than for SSRIs, but not as good as estrogen.
Yeah.
Yeah, so I think that they're a really great option for someone who can't take estrogen. I think they are a little bit more effective than SSRIs and have a little bit less side effects. But as you mentioned, with fezolinetant specifically, there was an issue in the clinical trials, and then just recently in a post-marketing patient that had a liver injury or some increased liver enzymes. They do recommend that you check liver enzymes at baseline, and then at 1, 2, and 3 months, and then 6 and 9 months after starting. And that is a change in the prescribing information. It used to be just at baseline and then 3, 6, and 9 months, but they increased it to monthly for the first 3 months to check liver enzymes. And that's because there was a hepatic cellular injury after about 2 months into someone taking it, developed symptoms and ended up having increased liver enzymes. For all these patients with either discontinuation or interruption, they did go back down to baseline. No one had any long-term liver failure or anything like that, but it is something to watch fairly closely.
Yeah, and they were looking because earlier drugs in this class had significant liver impact. So as
Right.
they develop further and further, they're getting away. They know what part of the drug is probably impacting the liver, and they're trying to get away from that. So that
Right.
brings up the topic of what's coming next.
Right. So Bayer has a similar drug. So the Astellas drug, fezolinetant, is just a neurokinin 3 receptor antagonist. The Bayer drug, elezanitant, similar but said a little bit differently. I think I said it right.
Hmm.
Is a neurokinin 1 and 3 receptor antagonist. And so far, the data doesn't look like it has as much effect on the liver. Who knows what the FDA will make people when it's not FDA approved yet. It's up for FDA consideration right now. When it is approved, it's quite possible because of the class of drug it is, the FDA will still make us do some liver enzymes. But it looks like for this drug, it has less liver effect.
Yeah.
I will say, just going back to Astellas, is that I do think it's somewhat onerous to have to do all these liver enzymes. I do think it's the safe thing to do. I definitely highly recommend it. It is not a significant, it's not like 20% of patients will have this, and the clinical data is about 2.3% of patients will have elevated liver enzymes versus 0.9% in the placebo. So I do like to remind patients or clinicians that it's not a huge number of patients, but there will be those people that will have it, and it's something you do want to be on top of.
Yeah. And then we got a question in the chat about coverage and cost.
Yeah, it's a great question. I haven't had that much trouble getting Veoza covered. If they're on Medicare, it can be very difficult, or Medicaid if they're on a government funded plan, that's very difficult. If they have private commercial insurance, generally a prior auth, because they usually have some contraindication to why they can't be on hormones, can often be helpful. Or Astellas has some programs that can help them. Astellas is trying to make the drug more attainable for patients on a cost basis. And so they're getting in touch with the reps sometimes can be helpful to try to get those coupons or find the right way to get them. Are you having trouble when you prescribe it?
I'd say I'm about 50-50 on
Okay.
coverage. I mostly prescribe for people who really do have contraindications and also
Right.
have tried something else and failed it. Because that's the other
Right.
thing I'm seeing them asking for in the PA is, oh, well, have
Yeah.
they tried an SSRI or gabapentin or all these things? So I
Right.
usually have to write a bit of a longer PA for it, and then I might get it covered. The coupons are great, but they don't last forever. So I have some
Right.
patients who are very frustrated when they realize that the coupon's like a 6-month coupon and then they're stuck out of pocket. So
Right.
definitely, coverage is still an issue, and I'm, hoping more and more insurances will cover it because I think it's been a pretty life-changing drug for some of my patients.
Oh, definitely. It's definitely off-label to use it in breast cancer survivors because they did not do any studies in breast cancer survivors. But
They're
I think
actively
that
doing them in Europe right now.
no, they are, yes. But I definitely see like a lot of my hemonc physician colleagues love it for this, and I definitely have a good number of breast cancer survivors that are on this and have done really
Mhm.
well on it.
Yeah, that's a really good point to bring up because I think people have heard rumors that it interacts with tamoxifen or aromatase inhibitors, but it's actually safe to use with both of those, right?
It is, yes.
Yeah. It is not safe to use with estrogen. And I always
It
make
is
this
not.
point that estrogen will potentiate it or will stop its processing, right? So you'll get higher doses of Eosa if you take estrogen with it. So higher risk of liver injury. And, because you might think of it as something to add on if somebody's not getting excellent hot flash relief from estrogen or try combining the two. That's a no-go.
Right. And it's not approved for perimenopause. So if people
Right.
are in perimenopause and they have a contraindication to estrogen or want to try Veoza, it's not been studied in that. We really don't know what it's going to do to cycles and
Right.
things like that. So
Yeah.
definitely more studies need to be done on that and what that
Yeah.
does.
No, I think there's a lot more studies to be done in this class of medications.
Yes.
You did not mention as an option clonidine. Isn't that
Oh,
the old
yeah.
school one that we all used to give?
Yeah, it is not one that's recommended anymore. So an antihypertensive, it can have a lot of side effects and can have side effects when you stop it. So generally not recommending it.
Yeah, and that's where I wanted to bring up the NAMS position statement. So in 2023, North American Menopause Society, which is now the Menopause Society, released their 2023 non-hormonal position statement. It is an excellent reference, and they, as with all their position statements, they sort of review all the evidence for and against each sort of pathway and medication, including alternative therapies. A lot of
Right.
the data we're giving you today is from that. They just do a really nice summary, um, which could be a
That's
great
a great
reference.
statement. I thought it was a really, really well done statement.
Yeah.
Yeah.
So we talked about the FDA approved therapies. There are a lot of things that people will try. What's the craziest thing you've seen someone try?
Oh gosh. I mean, I feel like, with like kind of the cultural weakening of menopause and perimenopause lately, and a lot of like social media
Mhm,
influencers, there's like some really interesting stuff. And I think there's a lot of these, supplements or non
mhm,
FDA products that people are selling to help with these things. I think we get into this place of entrepreneur type people that are trying to make money, and women who are desperate to feel better in this time in their lives. And we kind of get this cross section of kind of some not effective, not necessarily dangerous, but potentially not
uh-huh.
helpful things that people have heard that could help. So definitely see people on some interesting
Yeah.
supplements or you know more
Yeah.
natural type products.
Yeah. And I always tell my patients, most of these aren't going to hurt you,
Right.
but there's always the caveat that nobody's actually looking at what's in the pill bottle. And
That's the
especially if
thing.
something's coming in from out of the country, there have been case reports of people on herbals that have come in from China or India and getting lead poisoning. So you're never 100% safe when something's not regulated.
Right.
Um, that being said, there are some alternatives we can use. So if you look at the position statement, that's where they really assess the data around each of these. And
Mhm.
when I'm talking about herbals and alternative things, I'm talking about anything that's not a medication that's FDA regulated. Um, I also always still look to the evidence. Just because it's not a medication doesn't mean you can't study it properly, right?
Right. Right.
So, what's been best studied and has the best evidence is actually cognitive behavioral therapy, especially for hot flashes. And it's a very particular style of cognitive behavioral therapy. And there are some books on this. I think there's even some apps you can use to do it yourself, but there are also practitioners who can do that. Clinical hypnosis has some decent,
Mhm.
I think NAMS calls it level 2 data.
Mhm.
So interesting. Weight loss, simply losing weight reduces hot flash symptoms. We know that women who are heavier have more hot flashes. There is not a single supplement that they recommend or herbal.
Right.
They
Right.
looked at all the available data, and basically none of them have any data when they're studied in the right way, which is a randomized controlled trial with a placebo, double blinded with a placebo. They tend to perform about as well as a placebo.
Right.
And placebos actually perform pretty well for hot flashes for the first three
They
months. You
do.
get like
They
a
really
20 to
do.
30% response rate.
Yes, they do.
So it feels like for a lot of women, they'll come and say, No, I was taking black cohosh. It really helped, but then it stopped helping. That's the placebo effect.
Right.
The herbals we tend to see the most of, I see black cohosh, I see evening primrose oil, I see raspberry leaf, I see soy derivatives. Those are probably the main ones. I know Bonafide has a whole line of herbals for
Yeah.
various things, but just
Yams.
in general,
That's
yeah,
yeah. Yeah.
yes. Maca, everyone's
Yeah.
favorite. Maca does
Yes.
everything, by the way, guys. It's gonna make you stop hot flashing and give you a great sex life.
Right.
I've seen I'm trying to think what else there is out there. Dim.
Yes. Yes.
And I have to read this one. Diindolylmethane. I think that's about what it is. Anyway,
Right.
which is interesting if you look it up on the web. It literally claims to do everything a woman could ever need from like birth to death. Like it's great for your periods. It makes you more regular. It makes you not cramp. It'll fix your endometriosis. It'll fix your PCOS. And then it's going to fix your perimenopause. And then it's going to fix your menopause. And nothing does all those things,
It's
right?
a miracle. It's a miracle
It's a
supplement.
miracle. DIM is a compound that's found in cruciferous vegetables. So I tell my patients if they're like big into the DIM, I'm like, eat a lot of broccoli. You'll
Yeah.
probably get more DIM and absorb more of it than you will out of a pill.
Right. Right. I
And
mean, I
then,
think, yeah, I was
yeah.
gonna say, I think they think that there's like, there's people are looking for something more natural. The
Hmm.
thing I tend to go to, and I didn't mean to interrupt your list, 'cause I
No,
think this is really
please.
good, but the thing I talk about is just lifestyle management sometimes, right? Like I think
Hmm.
menopause and perimenopause kind of happen at this time where we have like, I just feel like a culmination of a lot of things. Like if we have kids, like there's more stress with kids and
Mm-hmm.
relationships and aging parents and careers. It's kind of like this like kind of perfect storm of all these things. And I think it's a hard time in our lives to make sure we're doing the self-care that we need. And then when we
Right.
also don't feel good because we're having these symptoms, it's harder. And so when I think about the cognitive behavioral therapy and the acupuncture and the yoga, like I was reading through the
Mm-hmm.
position statement today, I always think, well, yeah, some of that's self-care. Some of that's like taking time to like
Mm-hmm.
manage your stress and like, those kind of things. And I always remind patients, like, I just want to make sure you're practicing some self-care, because
Mm-hmm.
that is like definitely, it's not the whole story for sure, but it's definitely an aspect of this, and I
Right.
think that it can help, at least optimize some of this as we're going towards symptom management.
That's actually a great point. And especially like if you bring up acupuncture, and there are a couple small studies that seem to show that it was beneficial, and then there's some others that show no benefit. So they don't recommend it. But I tell my patients, I have no problem with acupuncture. It's really a form of meditation and
Yeah.
relaxation, if nothing else. And we could all use that in our lives.
Right.
It's not, again, not going to hurt you.
Right. Yeah, and
And
that's what I
then
say
there,
about the supplements that you mentioned too. Like, I don't think
Mhm.
they're necessarily going to hurt them. I think I always tell them there's a large placebo effect. They may help you for a little while. I don't know how long they will help you.
Right.
So, kind of exactly what you said.
And then there are some single symptom supplements we sometimes see, like magnesium for sleep or relaxation. Again,
Mhm.
no problem with that. It'll keep you a little more regular, if nothing else. You and I were talking a bit about creatine,
Creatine.
which is getting a lot of press right now, perhaps because an influencer is now selling a supplement for it. I'm just gonna leave that here. But for both muscle building, because it's a protein, and also saying it'll also cure menopausal symptoms like brain fog. I looked into the muscle building literature, and it's
Mhm.
not really strong. It's
Right.
interesting. There was a great randomized controlled trial where they, for 2 years, took either creatinine or a placebo, and everybody did strength training and walking, and
Mhm.
both groups had equal bone health and equal muscle strength at the end of that 2 years.
Mhm.
So I don't think creatine's actually adding anything in that range. You had looked a little into the brain fog. There's like, well, maybe.
There was a review. I mean, maybe better
Yeah.
blood flow, that kind of stuff. I mean, I
Right.
guess the question is like, is it if you're taking creatine, does that mean you're building some muscle, doing more exercise? Is that,
Right.
more
Is
exercise?
that
Is that
what's
helping things? I mean, some of these things are harder to study. And then also when we don't have a big pharma company behind these supplements, it's harder to get like a really quality data that's like a randomized
right?
placebo controlled double blind trial.
Right.
So I think sometimes it's like we wish we had better data, but we have what
Hmm.
we have, kind of thing. So
Right.
again, probably something that's not going to hurt people to try, although they should make sure they have normal kidney function and that kind of thing.
Yeah.
But something that people could try.
Yeah, you and I have run into this in the research area where we see like young men who are bodybuilding and taking huge doses of creatine, and their urinalysis and comes back, and their blood tests come back ridiculously high. And you
Mhm.
have to wonder what that does to you long term.
Yeah, agreed.
So when we're treating symptoms like depression, anxiety, sleep,
Mhm.
how do you pick a medication in that realm? Like there are hundreds of SSRIs at this for SNRIs and combined, and how do you sort of think through the decision pathway for those?
Right. I mean, I think it kind of depends on what their symptoms are and, what
Mhm.
side effects we're scared of. And we think about these medications, all SSRIs can tend to have, some of the symptoms we're trying to avoid, like sleep issues. Some of them have insomnia associated with them. Some of them have, weight gain. Some of them have, sexual side effects. So people are coming in with those complaints and also seem depressed. Like we have to kind of pick and choose somewhat carefully. So, I think that Wellbutrin, it definitely tends to have less sexual side effects, so definitely doesn't have as much of an effect on libido, or orgasm and arousal, things like that. So that's one I would start more easily. I do talk about how Paxil is the FDA approved one, but definitely most of the SSRIs would be something that could help vasomotor symptoms if we're thinking about that specific thing. But if
Mhm.
we're thinking about just for depression, anxiety, I mean, I think it kind of depends on goals and side effects and their other medical issues. Do you
Yeah,
have
that's a
a
great point.
specific way that you think about it?
I think about it very similarly. I'm a big fan of Wellbutrin in the perimenopause and menopause because of what you said. It doesn't have the sexual side effects. It tends to be weight neutral or even weight loss inducing. So you're
Right.
not going to get the weight gain. The downside is if they have an anxiety component, it can worsen that. So you have
Right.
to
Yes.
be
I
conscious
should have
of
mentioned
that.
that. Yes.
Yeah. And ADHD, it can actually help treat ADHD. It's a mild stimulant. So you don't want to give that to someone who can't get to sleep though.
Right. Right.
So if someone really, if I think a sleep is a large part of their problem, I might actually go with a venlafaxine or something like that
Right.
because it tends to be sedating. So have them take it at
Right.
night and it tends to help
Right.
with some of that insomnia.
Yeah.
Yeah.
I'm personally a big fan of gabapentin at night.
Hmm.
I find, and I don't, the papers are look at like, for vasomotor symptoms, look at like 900 milligrams. Like that's a dose I've never had put anybody on for gabapentin. Generally, it's so much gabapentin. But like 100 milligrams at night before bed, and then you can titrate up to 300 milligrams. For most people, not all, will not be sedating in the morning. And I
Hmm.
feel like it does kind of like, because it's like that neuromodulator, I think sometimes it calms down that like, I don't know, that anxiety thing that
Yeah.
happens in the middle of the night when we wake up and then get in that circular loop I was talking about. Like I said, not from
Hmm.
personal experience, of course, just I've heard of.
Never. No, of course not. Not us.
And so, I do think it helps some people with that. And so then in turn helps sleep because it makes you sleepy. So,
Yeah, that's true. And then weight, of course, is a whole separate topic. We're going to have a whole webinar on weight management in the perimenopause and menopause at some point.
yeah,
But, every woman walking in the door who's gained 15 pounds wants Wegovy.
right,
And I think it's important just to bring up the fact that the GLP-1s especially have really not been studied in people who are not obese or with a
right,
BMI of 27 to 30 with comorbidity. So
right.
if you're seeing someone with a BMI of 25 or 26 and yeah, they put on 10 pounds, you know, first of all, they're never going to get it covered.
No,
Second of all, even if they can afford it for some period of time, they can't afford it forever. And we know there's rebound weight gain with these. So they're not a good
right,
solution for those
right,
things. And we haven't really looked at, what going on and off these drugs over time because that's what women are doing. They can afford it for like 3 months and then they come off for a few months and they go back on. We don't know what that does. That's not a studied pathway.
right.
I do think the companies are starting to look more at that. They want to look at these drugs in the perimenopause and the menopause and what are some specific
Yeah.
topics.
I mean, I think it'll be great for them to start looking at that because it's such a common, I mean, no, you see it in your practice too. So many women coming in who BMI is like 26, 27, 28. They're not
Hmm.
obese, but and they're doing everything. They're exercising,
Hmm.
they're getting 100 grams of protein, they're sleeping,
Hmm.
they're lifting heavy weights 3 times a week, and they're just like can't get off the weight. And then also, we know that we start getting some like insulin resistance in
Right.
perimenopause and menopause, and like that A1C starts creeping up a little bit. And, like what is, I think we just need more data on what does it look like for this group
Hmm.
of patients. But I agree with you. There's just not enough data yet. But
There isn't.
um,
And I also remind people, don't forget the other things that are out there. These patients might be a good Contrave candidate. So Contrave is Wellbutrin and naltrexone.
mhm,
And, especially if they also have maybe a little depression or, something else
right,
that Wellbutrin can help with, there are other pathways you can go down to give them a
right,
little bit of a help. Obviously, the GLP-1s cause the most weight loss, but other medications really can be helpful for them.
right, right.
And even the phentermine containing ones. I don't have a lot of personal experience with those because we prescribe via telemedicine, so we don't do controlled
Mm,
substances, but a lot
right.
of people get really good results with like the Qsimias.
Yeah.
Um, so I guess the conclusion is we actually do have a pretty good arsenal of options to present women who are not good hormone candidates or who are just hesitant. I think
Mm,
being out here in Seattle, we see a lot of medication hesitancy. Although it's always funny to me because they'll go to their primary and say, I don't want hormones, and they give them an SSRI. I'm like, well, that seems more medication-y to me than a hormone.
yeah. Agreed. Agreed.
But,
So
I think there are a lot of good options. It's about thinking through the whole pantheon of symptoms and how many things can you treat with one gun. Um,
yeah, absolutely.
And then the one thing we didn't really get a chance to talk about is sleep. And I always like to bring it up because sleep is such a huge issue through perimenopause. And the one
Mm,
long-term solution for sleep management either in the perimenopause and then long-term is cognitive behavioral therapy for insomnia. It's
yeah,
the
for
best
sure.
studied. It has the best data.
Yeah.
Sleeping pills are a temporary thing and they're not great in this type period because it's not like they're not sleeping for a week because something's going on. Like they're not going to sleep
Right.
for a couple years.
Right.
So helping them to fix their sleep patterns is the best thing we can do.
Right.
if they're maybe wanting to try a melatonin type thing, there is Ramilton, which is a melatonin agonist,
Mhm.
which doesn't seem to have some of the dependency and rebound insomnia of some of the other sleep medications. But
Mhm.
even that, fundamentally, it's about fixing what's wrong, and that's
Yeah.
CBTI.
Yeah, definitely. I mean, I think sleep is such an important factor in so many of the symptoms we see in menopause and perimenopause.
Hmm.
Like, I think it affects our mood, it affects our weight gain, it affects brain fog for sure. And so
Hmm.
when we're not sleeping, all those things are affected. And so I think sleep is a huge part of this.
Yeah.
So I agree. I have a person here in Seattle that I refer to that does a lot of CBTI for that stuff. So
Yeah.
it's helpful.
All right. I'm going to go to
Can
the
I can I
chat.
can I ask? Can I add one more thing? And
Yes.
it's something we
Yes.
didn't put on our thing to talk about, but I'm assuming a lot of people know this, but I just want to say this as a sexual medicine, sexual health advocate and gynecologist. I just want to say that despite all the things that I said that I wouldn't that are contraindications to systemic estrogen, none of those things are necessarily contraindications to vaginal estrogen.
Yes.
I almost didn't think about saying this, but I just want to say this that ACOG has a great statement about safety of vaginal estrogen in breast cancer
Hmm.
survivors, blood clot, history of PE or DVT, or history of heart attack or stroke. None of those things are contraindications to being on localized vaginal estrogen as FDA approved. So please treat your patients who have sexual pain, recurrent UTIs, dryness. They can all give them all the vaginal estrogen.
Agree with you 100%.
Sorry,
Everybody
I
gets
just say
vaginal
that.
estrogen. I told a
Yes.
patient that yesterday. She came seeking hormones at 15 years into menopause. I said, I'm not going to give you systemic, but you can have vaginal.
Yeah.
Split the
Yeah.
difference.
Yes, definitely.
There are a couple more questions about Veoza in the chat, so I'm going to sort
Sure.
of pose them to you and sort of
Okay.
asking about how long can we use this? Do we know about long-term use? Like, what is the long-term impact on the liver? We only check LFTs to 9 months. If they're fine at 9 months, do we ever have to check again?
Right.
What's the thought
Yeah,
on
so it's a
that?
great question. I think in the clinical trials, when they saw elevations, it was generally in that the early period. So that's why like they're doing you have to check monthly for that first 3 months. That's statistically the most likely time you're going to see it. I mean, the clinical trial went for a year, so we don't have any clinical data beyond a year. I'm sure we're looking at more things now that it's been FDA approved. But I think that but most likely, if they're going to have a liver injury or liver issue, it would be in the first couple months or in that first year. So after 9 months, you don't have to keep checking them. I think you could cancel the patient like if you wanted to check them every once a year ongoing. I don't think there's a right or wrong answer. I usually kind of come talk to my patients about what do they feel most comfortable with.
Hmm.
There's nothing that says you have to go off Veoza by a certain time. There's nothing that says you have to taper down, or people often ask me, how do you go off of it? Can you just stop it? I mean, yes, there's not, in the clinical trials, they just stopped when they got to the end of their 52 weeks. So, we don't have a lot of guidance on anything in particular for after a year.
Yeah. That's a really good point. Like all drugs, in the pharmaceutical clinical trial world, a year is forever, right? Most
Yeah,
things are
yeah,
studied for 1 year.
right,
And then we get a lot of post-marketing data
right.
and find other things out. So anyone who has questions, please put them in the meeting chat or the Q&A. We can see both of those. And we're always happy to answer questions. Ashley, is there anything we didn't talk about today?
I mean, I added my piece about vaginal estrogen.
Mm-hmm. Well,
And,
we mentioned the herbals from Bonafide, and they have one for hot
oh yeah,
flashes. They have Reverie,
there's
which is
no,
their
yeah,
vaginal
yeah, yeah.
hyaluronic acid.
Mhm.
They're now marketing a natural candy neuron blocker.
Oh, I actually haven't seen that.
Yes, yes. We don't know anything about that one, but certainly there have been no peer-reviewed literature that I've seen that tells
Right.
me that this has any effect. And then they market something for sexual function. What's
Yeah.
your experience with that one? Because
Yeah.
we didn't talk a lot about sexual function here, and I know
Mhm.
it's a huge interest area of yours. So
Yeah.
could you give us like 5 minutes on how to things like Addii Vyleesi, talk about the
Yeah.
bona fide product if you know anything about it, and how do
Yeah.
we use some of those medications? We're not going to do testosterone. That's next month. Everybody come back for
Okay.
testosterone next month.
Okay. I'll try to talk about testosterone. I mean, I think like in this time period, like in menopause and perimenopause, libido takes a huge hit for a lot of
Yeah.
women. It's super common. And, I always tell patients, let's take a big step back and look at all the factors. So before we jump into medications, I have to push the biopsychosocial aspect of this, because it's not one thing. If you don't think about all the aspects of your life and your relationship that are affecting your libido, and you just went on a medication, I think your benefit's going to be is going to be less effective. You're not going to get as much benefit as if you actually think about the fact that you lay awake at night for 3 hours a night worrying about things, and you're exhausted all the time, and how that affects your libido, right? So, there's definitely stress, fatigue are some of the big ones. Pain is a big one that I see. Like, so often patients come to me menopausal and tell me they have low libido, and when I ask them if they enjoy sex, they say, no, it hurts. If something hurts, you're not going to want to do it. Like, we have to address the pain before we can actually think about trying to make you want to do it. And then other medications we've talked about, being on SSRIs, how that can affect things, or even just mood in general. Like, if you're having a lot of anxiety, depression, both those things can definitely affect your sex life. Partner relationship issues, and then medical issues for your partner. So definitely thinking about what are all the factors. But yes, there's 2 FDA approved medications for premenopausal women for hypoactive sexual desire disorder, which is basically low libido without any identifiable medical cause. So Addyi, or flibanserin, is the first one that was FDA approved, and it's similar to an SSRI. It's a serotonin modulator, and it's something you take nightly. This was the one that originally had a REM with it, like a special educational thing that you had to do that for clinicians and patients had to sign a thing saying they wouldn't drink any alcohol. That's all been lifted. So you can drink alcohol with it. You just don't want to drink more than 2 servings of alcohol within 2 hours of having it. You take it nightly. Side effects can be sleepiness. So I have some patients that actually feel like it really helps with their sleep. But we do see about 60%
which will help with your sex life, because if you're better rested,
it does. About 60% of patients will respond to Addyi. So I definitely think it's not, people look at the clinical data and say, oh, it's not that impressive. Well, I mean, it's another place where we see huge placebo improvements, because when you take women with low libido and make them do a diary every night about their libido, it improves. And they take something that might be helping. Yeah, they think about sex every day. So I do, I do think that there's a big placebo effect, but Addyi, about 60% of patients will actually respond to it. So I do think it's a good thing to have in your toolbox. And then the other one that's FDA approved is Vyleesi, or bremelanotide. And this is a medication that is basically a derivative of self-tanner. And it's an injectable medication. So it comes in a preloaded injectable, which I think used to be kind of a hard sell, but now that we're on like in Ozempic world, like it's like, okay, I'll inject another thing at this point. I don't think people care about that anymore. So you inject it 45 minutes before you want to have sex. It actually lasts for about 24 hours. So, it's something that it can keep you going you can get effects from it for quite a while. The big side effects with it is that people tend to feel nauseous the first 2 times they use it. So I always prescribe Zofran with it. I do think that patients, I think it's how you sell it to patients, because if you tell them, oh, it's injectable and you're going to be nauseous and like, ugh, but if you actually tell patients, a lot of patients like this because they don't want to take something every night for something they don't want to do every night. You take it when you want it. And actually, it similar to Addyi will reduce the inhibitions of kind of that, no, I don't want to have sex, kind of reduces some of that. And like I said, it can last for quite a while. So those are the 2 that are FDA approved. What's hard is that there is some data that they also be helpful in menopausal patients. There's no, but the problem is that they're only FDA approved for premenopausal patients. So good luck trying to get an insurance company to pay for something that's off-label like that. And they're not inexpensive.
They're not, but they both do pretty decent coupons, especially if you send it through the pharmacies online like BlinkRx.
Yeah, so they each have their own. Addyi is the Fill RX, and the Vyleesi is the oh gosh, I just had it in my brain. The Nippy, KNIPPERX, and those are the ones that they are specifically contracted with, and they will help you with the coupons and things like that.
Yeah, and that's on their websites, which Britt has very carefully put into our chat, which was so nice. Yes. And then someone else put up a question about, well, if you look at online and discussion boards, people are saying that transdermal estrogen has no risk of clot, so are DVTs, PEs really a contraindication? I'm actually going to talk to this a little because I actually just did a deep dive into a lot of the literature around this. And it's a bit of a nuanced answer, but the first thing I want to say is transdermal estrogen is not zero risk for blood clotting. It is very low in most populations. And in fact, in women under the age of 60 on a 0.05 patch or lower, we don't see an increase in overall clot risk. But that being said, if somebody has a higher risk, that they weren't included in those studies. So that is in a population of low risk women with no risk factors for blood clotting. So you can't really take that data and apply it to people who have risk factors. Looking at recommendations from around the world, so like the British Endovascular Society, places like that, their feeling is that someone who had a provoked DVT, so that's someone who had a DVT with surgery or a major trauma, and no abnormal clot risk otherwise determined by blood testing, it's probably safe, they say, with good counseling to use a very low dose transdermal estrogen after menopause. It is 100% contraindicated in someone who's had a PE. PE can kill you. We don't know what kind of residual damage is left in the vessels of the lungs that could cause anitis for clotting. And again, these are not patients who are in any of these clot risk studies. Certainly not something I would use in anyone who's had an MI or a stroke or anything else that's vascular. And then obviously with the clotting disorders. So anyone who has a higher risk of clotting because they're homozygous for factor V Leiden, something like that, then they are not also candidates for these medication for hormone therapy after menopause. And you're just always keeping in mind, we have this set of data that says these low dose transdermals don't cause increased clotting in low risk women. No one will ever study it in high risk women.
You can't.
You can't. So, but you also can't just translate the data over.
Right. Yeah, I mean, I have a handful of patients that have, had a DVT after their knee surgery when they fell asleep with their foot on, foot up, kind of thing, like a provoked. And with a lot of counseling on a transdermal patch, but PE is a hard line for me because that's
it's not worth the risk, is what I tell patients who come to me that. They're like, well, I'm really symptomatic. I'm like, yeah, but the symptoms will end. And I have all these other things I can offer you that we just discussed.
It's not a dead end, right?
There's not a dead end. And the risk when you've had a PE, when you've had an MI, when you've had a stroke is just too high. It's too high to make it reasonable. All right. Looks like I don't see any more questions in the chat. I'll give people one more minute while I'm thanking Dr. Fuller for her incredible knowledge base. Thank you so much, Ashley, for participating today and talking about all these things with me. It's always nice to see you. We work a lot together, but we rarely actually see each other face to face. So it's been fun for me too.
Funny.
And folks, if this is of interest, send it to your friends. They can find the video of this webinar on YouTube. They can register for the next one. You'll get an email with the video. If you registered, you'll get an email in a couple of days that has the link to the video and information about the next webinar. So you can register for that. And we're going to keep doing these monthly. We're going to move them into the evening at participant request. So the next one will be at 5 p.m. Pacific, 8 p.m. Eastern. So people are out of clinic and can attend better. And if you have ideas for topics that you want to hear, most of you can find me somewhere, either on Facebook or you can email me at drrebecca@genev.com. And thank you all for coming. Take care.
Thanks for having me.